Picture this. A 68-year-old man walks into your rural ED. 3 days ago, he had a minor stroke. Left-sided weakness that resolved within an hour. You've started him on clopidogrel and aspirin. The CT shows a small non-lacunar infarct. He's got some carotid plaque, but not enough for surgery. You sent him home on dual antiplatelets for 3 weeks, then single therapy long-term. And you hope. Because despite everything we do, about 5 in every 100 stroke patients will have another stroke within a year. Good morning. It's Monday the 27th of July. 4 stories today, plus a couple of quick hits. And the first one could genuinely change how we prevent recurrent stroke. Story 1. Oceanic stroke. Published in the New England Journal of Medicine in April this year. The question is simple. Can we do better than antiplatelets alone for secondary stroke prevention, without paying the price in bleeding? Enter asundexian. It's an oral inhibitor of activated factor 11, also called factor 11A. Now, factor 11 sits in the intrinsic coagulation pathway. It seems to have a minor role in normal hemostasis, but a bigger role in pathological thrombosis. People born with factor 11 deficiency have fewer ischemic strokes, but they don't bleed much more than the rest of us. That decoupling, thrombosis without bleeding, is the holy grail of anticoagulation. And it's exactly what drug companies have been chasing. Oceanic stroke was a phase 3, double-blind trial. Over 12,000 patients across 37 countries. Anyone within 72 hours of a non-cardioembolic ischemic stroke or high-risk TIA, as long as they had evidence of atherosclerosis. They all got standard antiplatelet therapy, either single or dual. Then they were randomized to add either asundexian 50 mg once daily, or placebo. Median follow-up of 19 months. Here's the result. Ischemic stroke occurred in 6.2% of the asundexian group, compared to 8.4% of placebo. That's a 26% relative reduction. Put it another way, for every 53 patients treated for a year, you prevent 1 stroke. No increase in major bleeding. 1.9% in both groups. No increase in intracranial hemorrhage. No increase in fatal bleeding. Now, the skeptic in you is right to ask questions. This is a buyer-funded trial. Asundexian is not yet approved by the TGA, not PBS listed, and probably won't be for a year or more. So this is not a change you make tomorrow story. But it is a proof of concept story. Factor 11A inhibition works for stroke prevention without causing bleeding. That's new. And when this drug does land, it's going to slot into a gap we've never been able to fill. The ability to add long-term anticoagulation to antiplatelet therapy in stroke patients, without the hemorrhagic trade-off. Worth knowing about now. Quick note. The sister trial, Oceanic AF, tested asundexian against apixaban in atrial fibrillation. That one was stopped early because asundexian was worse. 3.8 times more strokes. So this is not a universal anticoagulant. It works as an add-on to antiplatelets in non-cardioembolic stroke. Not as a replacement for DOACs in atrial fibrillation. Important distinction. Story 2. Tell your wife about this one. The Lancet just published a major series on postpartum hemorrhage, the 4th of July. 3 papers covering epidemiology, diagnosis, treatment, and prevention. The prevention paper is the one that matters for your daily practice. It includes a Cochrane Network meta-analysis. 122 trials. Nearly 122,000 women. The question, what is the best uterotonic regimen for preventing postpartum hemorrhage? Here's what they found. The 2 most effective regimens were oxytocin plus misoprostol, and oxytocin plus ergometrin. But those combinations came with more side effects. Nausea, vomiting, hypertension, particularly with ergometrin. For single drug prophylaxis, oxytocin and carbetocin were the most effective, with the fewest side effects. The recommendation is clear. Routine prophylaxis should be a single agent, either oxytocin or carbetocin. Save the combination regimens for women at genuinely high risk of PPH. And here's a shift. Ergometrin alone, and the oxytocin plus ergometrin combination, are no longer recommended. The hypertension-related safety concerns outweigh the benefits. That's a change from older practice where symptometrine, the oxytocin-ergometrin mix, was standard in many units. For caesarean section specifically, there's a separate network meta-analysis in Lancet Global Health that looked at 167 trials, nearly 45,000 patients. Carbetocin alone and oxytocin plus tranexamic acid both outperformed oxytocin alone for reducing PPH. Carbetocin had the better hemodynamic profile. Less blood pressure fluctuation. Single dose, no infusion needed. Why does this matter to you? Because in a rural setting, you might be the one giving the uterotonic at a caesarean, or advising on it. Carbetocin is PBS listed in Australia for caesarean delivery. And the evidence now strongly supports it as a first-line agent. If your unit is still defaulting to oxytocin for elective sections, especially in high-risk patients, this is the paper to take to your next quality meeting. Story 3. A bone health story you may have missed. It's from the New England Journal, published early last year, but it's a 10-year trial and it hasn't got the attention it deserves. 50 to 60-year-old women. Early postmenopausal. Not osteoporotic. Bone density T-scores between -1 and -2.5, or even normal. The question was, can you prevent fractures with just 2 doses of zoledronate, given 5 years apart? The trial was led out of New Zealand, funded by the Health Research Council. Over 1,000 women, mean age 56. They were randomized to 3 groups. Zoledronate at baseline and again at 5 years. Zoledronate at baseline only, then placebo. Or placebo at both time points. 10 years of follow-up. Over 95% completed the full decade. That is extraordinary retention for a prevention trial. The results. Morphometric vertebral fractures occurred in about 6% of women who got at least 1 zoledronate dose, compared to 11% in the placebo group. That's nearly a halving of vertebral fracture risk. The benefit of the second dose at 5 years was modest, suggesting 1 dose does most of the heavy lifting. Fragility fractures of any type were reduced by about 30%. Major osteoporotic fractures by about 40%. All from a single 15-minute infusion. Now, this is not about screening everyone with a DEXA. But think about the women you see. 55, early menopause, maybe on an aromatase inhibitor for breast cancer, maybe a family history of hip fracture. A single zoledronate infusion is cheap, it's on the PBS, it's well tolerated, and the data now shows it works for a decade. The number needed to treat to prevent 1 vertebral fracture is about 20. That's better than most interventions we offer in general practice. The caveat. This is a prevention trial in women with normal or mildly reduced bone density. It doesn't replace the standard approach for established osteoporosis, where you'd be using higher-intensity therapy. But it does raise the question of whether we should be thinking earlier about bone health before the T-score hits -2.5. Story 4. COPD. And this one's a mixed bag, but important because it opens a new door. Astegolimab. It's a monoclonal antibody that blocks the ST2 receptor, which is the receptor for interleukin-33. IL-33 is involved in both eosinophilic and neutrophilic airway inflammation, which means it could potentially work in COPD regardless of eosinophil count. That's the promise, because our current COPD biologics, like benralizumab and mepolizumab, only work in the eosinophilic phenotype, about a third of patients. 2 trials were published together in The Lancet in May. Aliento, the Phase 2b, and Arnasa, the Phase 3. Between them, about 2,700 patients with COPD and frequent exacerbations, all on optimized triple inhaled therapy. They got astegolimab every 2 weeks, every 4 weeks, or placebo, for 52 weeks. The results. In ALIENTO, the every 2 weeks dose reduced exacerbations by 15%. Statistically significant, but borderline. The every 4 weeks dose didn't reach significance. In Arnasa, the Phase 3, it flipped. The every 4 weeks dose was significant, an 18% reduction. The every 2 weeks dose missed, p equals 0.068. So what do you make of 2 trials where the winning dose changes? Honestly, it's a modest effect. About a 15% reduction in exacerbations, which is real but not dramatic. Compare that to the eosinophilic biologics in the right patient, which can reduce exacerbations by 30 to 50%. But here's why it matters. This is the first biologic to show any signal in non-eosinophilic COPD. The ST2 pathway works across the full eosinophil spectrum. That's new territory. Astegolimab is not approved, not PBS listed, and probably won't be until we see a cleaner result. But it tells us the target is valid, and the next generation of these drugs, or a different dosing strategy, might get us there. For now, in your COPD patients with frequent exacerbations, the message is unchanged. Optimize inhaled therapy. Check eosinophils. If they are above 300, a biologic like mepolizumab or benralizumab is your evidence-based option, and benralizumab is PBS listed for severe eosinophilic asthma. For the non-eosinophilic patients, we are still stuck on inhaled therapy and smoking cessation. But the pipeline is moving. Quick hits. The Australian and New Zealand College of Anaesthetists has published its first essential medications list. This is a list of drugs considered critical for safe anesthesia and pain medicine. More importantly, it includes substitute options for when there's a supply shortage. If you work in a rural hospital where drug supply disruptions are a fact of life, bookmark this list. It's been distributed through national pharmacy networks and will be updated periodically. And from the TGA. A safety alert from the 8th of July. Counterfeit products sold as honey sachets, marketed for sexual enhancement, have been found to contain undisclosed prescription-only medicines. These are being sold online and in some retail outlets. The risk is serious: interactions with nitrates, uncontrolled blood pressure drops. Worth asking about when you see a patient with unexplained hypertension or a strange medication interaction, particularly if they've bought something online for performance enhancement. Recap. Asundexian, a factor XIa inhibitor, reduces recurrent stroke by 26% when added to antiplatelets, with no increase in bleeding. Not yet available, but practice-changing when it lands. The Lancet PPH series confirms carbetocin and oxytocin as the best single-agent prophylaxis, and ergometrin is out. 2 doses of zoledronate, 5 years apart, halve vertebral fractures over a decade in early postmenopausal women. And astegolimab shows a modest but real signal in non-eosinophilic COPD, a new target for a hard-to-treat group. See you tomorrow. Stay sharp.